We have Dr. Mbabazi lined up. Then I think we'll be taking questions at the end of the session. Dr. Mbabazi is a research fellow at Makerere University Lung Institute and also a radiologist. Dr. Mbabazi, you're welcome.
Okay, so good afternoon, everyone. I'm going to discuss briefly the radiological screening of lung cancer. Dr. Mbabazi Margaret, a research fellow with the Makerere Lung Institute. Lung cancer screening in the past was done using chest X-rays or sputum cytology, but these have been found to offer no mortality benefit. And why is this? Because by the time lung cancer manifests as a nodule on a chest X-ray, most times it is already a mass at about stage 2 to 3. And lung adenocarcinoma, which is the common histological subtype of lung cancer, usually starts off as a ground glass nodule. Later, it may transform into a part solid nodule, but all these cannot be seen on X-ray. So through research, it has been established that high-risk patients should be screened with low-dose CT scan, and this has showed marked reduction in mortality. So what happens in the Western world is that patients who are high risk, and those are patients who are between 55 to 74 years of age, who are current or former smokers with at least 35 pack years, and within about 15 years of smoking cessation, receive annual low-dose CT scans. In a setting, we still need to determine the population at risk of developing lung cancer. And then once we have determined this population, we can establish a screening program using low-dose CT scan. But what is low-dose CT scan? Low-dose CT scan is exactly that. The amount of radiation that is delivered into the body is about 1 millisievert for males and about 1.4 millisieverts for females, which is really small when you compare to a routine chest CT scan, which delivers about 7 millisieverts for a standard diagnostic chest CT scan. So because the doses are so small, we can screen someone several times without really giving them doses that are worrisome. And then low-dose CT scan is performed without contrast media during a single maximum inspiratory breath hold. The scanning time is less than 25 seconds, and then the rest is really a matter of reconstructing the images. So this is able to detect even the smallest of nodules and also delivers very little radiation to the patient. After screening, then the findings are interpreted using the lung grads. This is the version 1.1, which is what we're using currently, and you can Google it and internalize it, or you can put it in the reading room to help you as you read the CT scans. But essentially, you're going to find two types of algorithms. There's the Fleischner guidelines, which are for incidentally detected nodules. Supposing someone came for something else and then you detect a nodule, there are guidelines for that, which are the Fleischner guidelines. But for screening programs, we tend to use this lung grads, and the scores range from 0 to 4x, from incomplete, negative to highly suspicious. And then in the fourth column of that lung grads, it gives us a hint on how to proceed. Should this patient go home, and for how long, and when should they come back for the next CT scan? Now, in our setting, we have a problem of tuberculosis and post-TB lung disease, which radiologically or radiographically mimic lung cancer. So a study done in South Africa, which is also a high TB endemic area, decided to set their nodule size to greater than 6 millimeters. So that if a patient comes for baseline low-dose CT scan screening in a highly TB endemic population, and you discover a nodule which is greater than 6 millimeters in diameter, that is considered positive. And if the nodule is non-calcified, solid or partly solid, between 6 and 10 millimeters with no malignant features, then we can repeat the low-dose CT in 6 months. If it is greater than 10 millimeters with additional malignant features, then we need to take further action and exclude lung cancer. And I think if we try to adapt this algorithm to our setting, it will help us to be able to detect lung cancer, which has been managed as TB for a long time. Now, for patients who smoke in the Western world and the other settings where they have a screening algorithm, this yearly screening continues for about 15 years after smoking cessation, or when the patient becomes too old that even if you detect lung cancer early, they would be unfit for curative management. For the Ugandan situation, we still don't know how long we would have to screen, but this is something we need to work towards. So just a few nodule characteristics that we shall see as we screen. The key aim is to define whether this nodule is benign or malignant or suspicious. And if it is suspicious, to have a plan of how to follow it up. So this is a lung window. This is a mediastinal window. And in this CT scan, we see a nodule which has a well-circumscribed margin and a small eccentric calcification. If I saw this, I would worry because of the location of the calcification. But when we look at the mediastinal window, we find that on top of the calcification within this nodule are fat components. So a nodule which is well circumscribed with a calcification and fat components is usually a hematoma, and it is a benign nodule. Now, usually adenocarcinoma starts off as a ground glass nodule, a purely ground glass nodule. Ground glass means that you are able to see the pulmonary vasculature within the nodule, through the nodule. So it's like having glass that has been fogged. So in this image where the arrow is pointing, we can see a purely ground glass nodule here. And the surrounding vessel has not been affected by the presence of this nodule. So using the lung rads, we would measure the diameter of this nodule and then decide on a follow-up pattern for this nodule. But when this patient came back after 2 years for a repeat scan, within this nodule, they have developed a solid component. So already we know that this is not an innocent nodule. So by following them up, we are able to pick this lung cancer while it is still stage 1, and we can actually offer curative services for this patient. And for ground glass nodules, we keep an eye on the solid component. So in this patient, this is the size of the ground glass nodule, but within it we have these white areas which are the solid components. Somebody's talking. Could you please mute? Okay. And then in this patient here, we have a speculated solid component within partly within a ground glass nodule. So this one, we are almost sure that this is lung adenocarcinoma. This is highly suspicious because of the large ground glass component and also the large solid component. So after we have seen this, then we go back to the guidelines and decide on when to follow up this patient, or when to offer surgery, or when to treat. Now, this is another ground glass nodule, but after follow-up, we found that this nodule had disappeared. So sometimes you cannot just decide on the initial scan, and that's why we need an algorithm for follow-up so that we can decide what happens next. So this one, after the follow-up CT scan, it had disappeared. So this was most likely an inflammatory ground glass nodule. Now, for the solid nodules, which are purely solid, we then look at the margins, and our biggest indicator of malignancy is usually speculations from the nodule. So when we look at this nodule, yes, it is solid, but its margin has spicules coming from it. And if you're not sure about the speculation, you look at the surrounding vasculature, and you can see that it is trying to pull the adjacent bronchial and also the artery, and also the pleura is being dragged towards the nodule. So this is a highly suspicious nodule. Now, in our setting, because of TB, we are also going to meet many calcified nodules. So the pattern of calcification is also something that we need to pay attention to. For image A shows a nodule which is at the center, which has a calcification at its center to give you a sort of bull's eye appearance. And this tends to be a post-TB granuloma, which is really benign. In image B, we have a nodule which is entirely calcified. This also tends to be a benign granuloma. In image C, we have a nodule, but it has a lamellated pattern of calcification. And this one also tends to be benign. Then image D has what we call popcorn calcifications, which are characteristic of hematomas. But when you get to image E, we're seeing several eccentric punctate nodules, calcifications within an ill-defined nodule. And this is one which is suspicious, and it turned out to be a malignant carcinoid. Now, for image F, we have a calcification almost close to the one that I showed you earlier. It is eccentric. It's not within the center of the nodule. And when you look at the margins of the nodule, there are some speculations along the margins. So this would actually be a calcification within a malignant nodule. So because of TB, we need to really pay attention to the pattern of calcifications that we see. And that, coupled with the margin and the size of the nodule, can help us to decide whether it is malignant, benign, or just highly suspicious. Thank you.